Let's go ahead and get started. We got some troopers on the line here, so we got some pretty good cases for you guys this morning. And actually, there's a pretty good book that I'd actually seen it before, but I ran into it again. It's called Making It Stick. It's written by a couple of psychologists. It's how to make things that you learn stay in your brain longer, and it decreases the forgetting. So normally if you learn something and then you sort of quit studying it, I mean, it just trails off pretty quickly. But if you do things like unknowns like this, where you sort of don't have any theme and you just kind of throw something out and you do it, you don't feel like you're really mastering any individual little topic, but you learn more and it stays with you more over the long haul. So it's sort of not gratifying initially, but the learning curve, it's been scientifically shown, is better if you kind of do stuff kind of randomly. So these unknown sessions are really, really good for you guys. So somebody want to give this one a go?
Yeah, I can. All right, this is a punch, and location-wise, I'm thinking like probably like an extremity or the trunk. Just there's fat there, and I'm not seeing a lot of terminal hair follicles or anything like that.
Good, exactly. And that's where, like we say before, that's where you take 90% of your biopsies if you can, obviously.
Yeah. So just at this low power, I'm noticing two things. Number one, it looks like there's some orthokeratosis, and I don't know if there's truly like a split in the stratum corneum, or if that's sort of artifact, but it looks like there's mostly ortho. There may be some para in there.
Good. So inflammatory disease, right?
Yeah.
And which pattern do you think this is mostly here?
I don't want to say lichenoid, but it does look like it could be like a little interface.
Good, good, excellent. Yeah, it's an interface dermatitis. And it's not really lichenoid. You're right. It's got some perivascular infiltrate. It's almost kind of band-like in a couple of areas, but mostly it's interface. And what's going on right here?
Yeah, there's vacuolar interface.
Good, excellent. And that puts you into a relatively small differential diagnosis. What about over here? What are these structures I'm kind of pointing to in these areas right here?
Are those just dyskeratotic keratinocytes?
Good, dyskeratotic keratinocytes. So what's the infiltrate composition?
Looks like largely lymphocytes to me.
Good, excellent. Mostly, almost all lymphocytes, no eosinophils, no neutrophils. So it's a superficial perivascular dermatitis with interface vacuolar alteration. And then you notice at low power that there was something going on in the cornified layer. And so as we look at it, higher magnification, this is basically cornified layer. What's going on here?
Looks like a lot of para and I think those are red blood cells.
There are some red blood cells over here, but look carefully at this structure right here. This is a very, very good slide to learn from. I've seen seasoned dermatopathologists, guys trained in dermatopathology, miss this.
Yeah, I guess that's a coronoid lamella.
Well, not really. So keep looking. So let's look over here.
Unless it's an organism of some sort.
Well, keep looking. You have to sort of be creative here. So let's go back in our mind and think. So we got a vacuolar interface dermatitis here. And then what happened? Let's say this is maybe a week old, this biopsy. So now, if we look at the cornified layer, it's basket weave, right? So it probably wouldn't even be scaly. In order for it to be scaly, it's got to have some kind of altered cornified layer. It's got to have some parakeratosis or maybe some laminated orthokeratosis, like an ichthyosis type thing. But if it's basket weave, generally if it's scaly at all, it's very fine scale, if any. So it tells you that really, if something happened here, it really didn't even have time to alter the cornified layer. So let's look at this one more time here. So imagine so this is a week old. Let's say we go back to maybe to day 2 of this situation. So it's an inflammatory skin disease and vacuolar interface. What happens if you have something that's putting little holes at the DE junction? What can happen if you do that and you kill keratinocytes there?
I mean, you get, I'm thinking like Collarets scale or like.
Well, but can it just kill the epidermis?
Yeah.
You get these dyskeratotic keratinocytes. So in this case, it killed the entire epidermis.
Okay.
So fluent epidermal necrosis, a blister. So it's a real honest to goodness blister. There are red cells sitting in this space. This isn't just a cleft. It's not an artifact. This is actual a vesicle. And then what happened?
Mm-hmm. And then is this just like reepithelializing?
Yes, good. This is reepithelialized. So this was an acute blister, killed the epidermis, sloughed, and then reepithelialized. So it's about a week later. So it's actually reepithelialized. So is this an intraepidermal blister?
I think so.
No.
Oh, it's sub-epidermal, so it's reepithelializing now.
Yeah, and I've seen guys miss this. In fact, I've seen guys go down that sort of cul-de-sac that you did and say, oh, that's just, all cornified material and crust. Well, no, it's not. This is basically kind of an eschar, and this is an important clue to this diagnosis. So what disease do you know that can totally kill the epidermis really fast? That's a vacuolar interface dermatitis with an infiltrate relatively sparse, usually, of lymphocytes. What disease does that?
I would think like EM or SJS.
Yes, good. Erythema Multiforme or Stevens-Johnson syndrome, or what's the other one in that family of diseases?
You mean in that spectrum?
Yeah,
TEN.
The most serious one. Yeah, TEN. And, some people, and I think there's sometimes some truth to it, that if you look at TN, it's got less of an infiltrate than EM, but not always. I mean, I've seen some cases that look just like this involve 90% of the body. So you want to make this diagnosis obviously as quickly as you can, because you never know. I mean, if they got classic iris and target lesions in the palms and soles and maybe a couple in their lip and everything, and you say, oh, this can be pretty classic erythema multiforme. A couple of days later, it may be widespread Stevens-Johnson and even get more widespread and become sort of like TN. So I'm a believer that it's all in the same spectrum. And I don't just kind of, go home and see you next week kind of situation if somebody's got erythema multiforme. They need to be followed and watched kind of carefully, because you never really know for sure whether they're going to possibly progress to TN. Most of the time they don't, but I've seen some that have, and I've been burned by it. So I just would be cautious about it. But this is a good example of confluent epidermal necrosis. So this is total epidermis is necrotic here. Everything is dead. And it happened really, really quickly. This is like the guillotine. It lopped off their head quickly. They died fast. It didn't even have a chance to form any parakeratosis. Now, there's one other disease that's in that spectrum of EM, TN, Stevens-Johnson. What's the last of the diseases that falls into that spectrum?
I don't know. Sometimes I think about fixed drug, but I don't see it.
Good. You should think about that. Those are all the ones that sort of all give you that same sort of interface dermatitis with confluent epidermal necrosis when it's really florid, and then can reepithelialize and can do it really quickly. Now, you're right. Fixed drug eruption wouldn't be that good for this one, because it's usually superficial deep infiltrate, melanophagous, because it keeps occurring at the same site over and over again. And it's got eosinophils in the infiltrate. So this is not fixed drug. That if this is a multiple choice question, that wouldn't be the best answer here. But erythema multiforme would be the best answer in this case, or in that spectrum. So that's good. But just the main teaching point is this. I really want you guys to be able to recognize this, because you'll see this. And yeah, they could possibly put this on the exam. They could show a reepithelialized blister that confluently killed the epidermis.
Can I ask a quick question, Dr. Cockerell?
Yes.
How can you tell that this is a blister, like a sub-epidermal blister that reepithelialized, versus a subcorneal vesicle?
Well, that's a good question. If you look carefully, this is dead epidermis here. It's dead. Subcorneal would have normal epidermis with the split occurring right in this area. So this is an eschar. These are all disc keratotic keratinocytes. They're fairly old. They're probably about a week old. So this is, it's critical. If you ever, hear the situation of somebody's comes into the emergency room and their total body exfoliation, and then you take some of the scale and you go down to the frozen section in the pathology lab and they do a frozen section on it. If you see this confluent epidermis here that's dead, it's TEN. If you see that, if you only see cornified layer, it's probably staph scalded skin. That's the classic differential diagnosis. So this is what you have to look at. Make sure you can recognize this. So this is totally 100% distinct from a subcorneal blister. That would be occurring in this area, and all of this would look like normal epidermis. If you had a subcorneal blister, it would look kind of like this, maybe, and something like that. If you had that, these are still disc keratotic keratinocytes here, though. So this really isn't a subcorneal blister. So just make sure you
got it. Thank you. Yeah. So it's the necrosis. It's just the
yes,
necrosis on the top part. Okay, got it. Thank you so much.
Good. Okay, let's take a look at this one. One of those fun biopsies that doesn't really have much epidermis, right? There's a little bit up here left.
I can go again.
No, I'll go. Yeah, so there's kind of just this, deep blue neoplasm.
Good. Okay, good.
Situated,
So
I'm
when
guessing,
you
in
look
the
at
dermis.
something like this, let's say that you've never seen this. Let's say this is a board exam question. They throw this up on the screen. You go, oh, you know what, and so just always, you can always take comfort in starting off with an approach. So you can take something you know nothing about, zero. It's just like wine tasting. If you don't know what wine is you're drinking, if you have an approach to it, even somebody says, okay, I'm going to call on you to speak about this wine in front of 100 people. If you have an approach and you know how to do it, you start off not knowing the answer. Say what you do know. What color is it? She said it's blue. It's in the dermis. So just proceed through. Is it inflammatory or neoplastic? Most likely it's going to be.
This looks neoplastic.
Yeah, neoplastic, right? Okay. Is it going to be more likely benign or malignant based on what we have here at this power?
A lot of it sort of looks well circumscribed, but it also looks like, not, I don't know. I'm kind of hedging a little bit, actually.
We would probably never just say at this power, oh, it's definitely benign and move on to the next case unless we wanted to get a lawsuit. So no, we wouldn't do that. We wouldn't make a diagnosis here, but we would say, well, based at what we see here, it seems to be fairly well circumscribed. It's, we don't have the whole thing, but it looks relatively symmetrical based on what we have here. So it's probably going to be benign, but we could be fooled. We may go to higher magnification, it may be metastatic melanoma, or something like that, or maybe a lymphoma. So, but we're just sort of saying at low power, it's probably benign, but we're going to go to higher magnification and see what else. Do we think it's epithelial or non-epithelial at this power? And you may not be sure, but it looks blue, and you say, well, it's doesn't look like keratinocytes, like sort of eosinophilic, like it might be if it was a squamous cell carcinoma. It doesn't really look like a classic basal cell. So it's probably going to be non-epithelial, but we're going to see as we go to higher magnification.
Right.
That's kind of what we do at low power. So we're going to go to high power now, and let's see what we see. So what's the, so do you think it's epithelial now looking at this?
No.
No, good. Why?
It kind of the shape of the nuclei.
Well, I would say that before looking at shape of nuclei, look at the shape of the cells. So
yeah,
if
they're kind of like
spindle in some cases, what kind of spindle here that favors non-epithelial. It doesn't have to be. You can have spindle cell squamous cell carcinoma. We know there's exceptions to every rule, but it favors that. What other kind of cells do we have here?
You've got these like giant cells there.
Yeah, that's sort of, where do we see giant cells usually?
And like fibrous tumors.
Yeah, fibrohistiocytic lesions. Exactly. That's the most common situation. And we can see, giant cells in herpes virus infection too, and giant cells in melanoma sometimes, multinucleated melanocytes. So there's exceptions to every rule, but you're right. Most of the time we see something that looks spindle and somewhat cuboidal, and we have multinucleated giant cells. That's going to make us think in the fibrohistiocytic category. Now, then we go to higher we look at higher magnification again. What else are we going to look for to think that it might be possibly benign or malignant?
I mean, just mitotic figures,
Good.
atypia of the nuclei.
Good. Pleomorphism of the nuclei, abnormal nuclear to cytoplasmic ratios. We look for atypical bizarre mitoses. Do we see any of those here?
I didn't see any.
Good. So we don't see that. And these are not mitoses here. They're just some dark nuclei. So that favors what?
Benign process.
Benign. Okay, so it's a benign fibrohistiocytic neoplasm of some sort. This would probably, if this is going to be on the exam, wouldn't just be pick it out of the cloud. They're going to expect, they'll probably give you a multiple choice, might give you several different things to think about. But what are some entities that you know that are in the fibrohistiocytic benign category that you're aware of at your state?
So these are, I mean, like these are not the type of giant cells in like a dermatofibroma.
Okay, so dermatofibroma is one entity in the fibrohistiocytic lesions. Good, that's exactly right. And there's a whole bunch of different variants of dermatofibroma, but I agree, this is not your typical dermatofibroma. It's fairly deeply situated. This is probably near acral skin. We don't really, that's a thick cornified layer up here, but this entity tends to occur on acral skin.
I mean, like, I feel like there's, you can then get into like angiofibromas or things like that, which again, this does not look like, right? So we're like,
this sort of veers a little bit away from classic dermatology, dermatopathology, a little bit into general pathology, but there are, and you should at least know of this entity. This is a giant cell tumor of tendon sheath. Okay. These lesions, these little cells here that you're looking at, are probably clasts. So you get osteoblast and osteoclast in these lesions. And this entity is in the family of the fibromatoses. Now, have you heard of the fibromatoses yet? You guys know anything about those? You need to know a little bit about it. This includes things like Dupuytren's contracture, torticollis, some of the other conditions that give you fibrotic lesions of the tendon. This is in that category. And it's also desmoid fibromatosis. And anybody know what disease that is associated with, it's a cutaneous manifestation of systemic disease that gives you desmoid fibromatosis?
Gardner's.
Yeah, Gardner's gives you cysts, desmoid tumors. So this is in the same category as desmoid tumors. Okay. So you should just at least know a little bit about this thing. I don't know that they probably wouldn't ask it on the exam. If they did, they'd probably show you one that was pretty classic, and they probably, again, would put it on like a choice. They wouldn't just expect you just to look at this and say, it's a classic, fibroma tendon, but it's got all it's got the classic features to it. It's got the
quick question on it. Like this feels like very dense. I don't know. Do you feel like this is a typical sort of example of this?
It's a pretty early stage lesion where the cells are pretty proliferative. As they get older, they kind of turn into more collagen. So this is probably one that's, maybe in an early stage of its existence. And if you left this alone for 20 years, it would end up looking probably more like a desmoid tumor or more like Dupuytren's contracture, that sort of thing. But, they had an article in JAMA or JAD recently. Warren Hyman talked about desmoid tumors and fibromatosis on the palms and Dupuytren's contracture. So it's out there, and you should at least know what it is. So it's good, but that's how you approach something that you really don't know. And you may not have seen one of those before. So now you have. This is beautiful. And this is a one they could very, very easily put on the exam for you here.
It's a punch biopsy. Looks like a square just from scanning, like a square punch.
Sure does. Looks square. Okay, good. So what does that tell you?
There's either some depositional process or a sclerotic process. I probably favor the latter with all the pink.
Excellent. Very, very good. That's exactly what you should think about. And so do we think this is deposit, or do we think it's more inflammatory here?
It's pretty sparse, but I do see some pockets of like blue cells that could be inflammatory. I don't see it like anything standing out to me to be depositional yet.
Good, good. So it's more inflammatory. Okay, and here you see, what kind of cells are we looking at here?
Looks mostly like lymphocytes.
Lymphocytes, and then there's some other cells with a little bit more cytoplasm in here interspersed with the lymphocytes. What are these cells?
Like the wavy cells, or?
Well, some of those are probably fibroblasts, but there are others that
Uh-huh.
have more cytoplasm.
Oh,
And
plasma cells.
well,
Okay.
there are plasma cells in here. That's good. They're
Yeah,
not here though, in this area. But what about
yeah,
over here,
the
these areas over here? You got these cells that are between your oncology bundles here.
oh,
The
histiocytes?
histiocytes. Good.
Okay.
Histiocytes predominate in some areas, right?
Mhm.
So if histiocytes predominate, what do we say at least part of the entity is
It's probably granulomatous.
granulomatous? Okay, we all know the 5 different patterns of granulomatous inflammation now. So which pattern is this one?
Probably interstitial.
And what, okay, interstitial, and we talk about interstitial, what pattern is that really in the umbrella does it fall under?
I'm not sure.
Palisaded
Okay.
granulomas. And when we think of palisaded granulomatous dermatitis, what are some of the entities that we tend to think of there?
I think GA,
Good.
P and GD.
What was, I didn't hear you. What'd you say?
Palisaded neutrophilic granulomatous
Okay,
dermatitis.
yes, good. That's good. Excellent. What's
I'm
the other biggie?
forgetting what I'm missing. I'm not sure.
What are we looking at right here? What's the diagnosis here?
At first, I thought this could be morphia because of the, I guess, like the lymphoplasmacytic infiltrate near the subacute junction.
Okay. Morphia is probably a choice. Okay, so we got
Okay.
multiple choice here. Morphia is in there. What's bad about morphia?
I guess I don't know if the sclerosis is as dense as I would picture. Like there's still spaces between the collagen, and also I don't think it's usually histiocytic.
This disease too can be very sclerotic. I mean, we're looking at the sclerosis right here. It does have some fibrosis left or right, but it's you know. But what we talked about palisaded granuloma, is that good for morphia?
No, it's not.
No, that's bad for morphia.
Okay.
We don't see histiocytes in morphia, so that's bad for it. But we get sclerotic collagen. So you got to say,
Mhm.
you know, it's sclerotic collagen. We see that in morphia. What other diseases can we get sclerotic collagen in?
Guess like I'm thinking like scleromyxedema, scleroedema.
Well, scleroedema really, it's probably a misnomer, really. The collagen there isn't really that sclerotic. It's just that
Okay.
it's very thick and it's got mucin in there. But scleromyxedema really also is sort of a misnomer. It's really not sclerotic collagen there either. It's really that proliferation of those fibroblasts that's present diffusely. It's almost kind of like, you know, the nephrogenic systemic fibrosis in a way. It's analogous to that. But here we've got histiocytes, palisaded granulomatous dermatitis, plus sclerosis, plus plasma cells, where we always see plasma cells almost with anytime there's sclerosis. It's not always, but 99% of the time. You're missing one disease that's in that list of palisaded granulomas. The good news is you'll never miss it again. So you got GA, you've got the very zebra rare interstitial granulomatous dermatitis associated with connective tissue diseases. What's the other there's two other big ones that I want you to know about.
Is it I don't see a lot of like necrosis, but necrobiosis lipoidica, like NLD, is that?
Okay, well, okay, so tell me, that's what the diagnosis is here, by the way. Okay, but notice that you let the name veer you off path. What is necrobiosis? Tell me what that is.
Like what you see in it, or the actual word?
Tell me what the word means. I can't stand the word personally. I hate it. And why do I not like it?
Maybe because you don't need to see a lot of necrosis. Is that?
Well, first of all, it means sort of death life, you know, death and life. It's kind of like yin yang together. I mean, it doesn't make any sense really. And basically what it refers to is degeneration of collagen, because you can't have collagen die, right? Collagen is a fiber. It's like the wood on your table. It can't die. You know, it's there. It's already no longer a living plant anymore. So this is degenerated collagen plus granulomatous inflammation. And people just say, that's necrobiosis. Well, it's really a garbage term. It's not that. It's the pattern is sclerotic collagen, degenerated collagen with palisaded granulomatous inflammation that occurs in this layered pattern. You've heard of the layer cake kind of pattern?
Yeah.
Here we go. This is it. Boom, boom, boom. That's the layer right there. And between these little granulomatous foci is the degenerated collagen. So you said, this can't be Necrobiosis lipoidica, because what's the necrobiosis garbage? Well, this tells you why that's confusing. So I don't want you to be confused. I want you to think in terms of what's the pathologic process that's going on here that's leading to this beautiful picture that we're looking at in front of us. And basically what happens is here you get palisaded granulomatous dermatitis, and in the center of the palisade is degenerated collagen. Whereas in the center of the palisade in granulomatory, what's in the center of that palisade?
Mucin.
Mucin. And what's the third big entity that we think of most commonly that you didn't mention of those?
I'm blanking.
Rheumatoid nodule.
Oh, okay.
What's in the center of the rheumatoid nodule usually?
It's usually more pink.
And what's that pink stuff? What is the pink stuff?
So it's not mucin.
It's fibrin.
Okay.
Fibrin. So when we talk about these various entities, you know, Dr. Al Kopf years ago used to call this the thesaurus, like thesaurus, you know, thesaurus moses, meaning like the thesaurus is actually a treasure chest. It comes from the Greek word thesaurus. Well, I guess probably Latinized, but originally it meant treasure chest. And so what's in the middle? What's the treasure in the center of the treasure chest? Whether it's degenerated collagen, whether it's mucin, whether it's fibrin. So you can think of this as this is the treasure chest right here, the palisaded histiocytes that are engulfed, that are kind of surrounding the degenerated collagen. So that's the way to think about this entity. It's not, I mean, you can use Necrobiosis lipoidica, but it's really not a very good name because it confused you. You said, well, there's no necrobiosis. Well, there is, but it doesn't exist as a real entity. It's just all that necrobiosis is degenerated collagen, and it's surrounded by histiocytes. So that's why I don't like the term, because it's kind of confusing. It's an old, it's like pseudopolyd, you know, that's a garbage term also. You know, it doesn't really mean anything either. So this is Necrobiosis lipoidica diabeticorum, and it's not always seen in diabetes patients, but it most commonly is. And so this is a great lesson in going over the palisaded granuloma. So we've had GA, we've had rheumatoid nodule, and now we've had NLD. And here are the plasma cells. They're commonly seen at the periphery of the sclerotic collagen and the fat. This is where you see, and even in morphia, this is where you see the plasma cells. I don't know why you get plasma cells in morphia. I keep telling the morphia experts they ought to look at that, because I really think that's somehow pathologic, because it's seen in all the sclerotic disorders. So good. So you've learned something on that one, hopefully.
Thank you.
Okay, let's take a look at this one. This one's also very interesting from two different perspectives. This is one you will not read about in the textbook, and it's one that you may not get right here because it's different.
I'm really good at being wrong.
Celebrate your mistakes, boy. That's where you really learn the most. You
This
really
is
don't learn
a
much when you get it right. It's sort of that just there's no new myelin form there. It's like, wow, I'll never forget that experience.
okay. This looks like a pretty large. If it's a punch, it might be an excisional biopsy.
It's probably a punch. It may be a 6 millimeter punch.
And it looks like, I think it looks inflammatory, like it's an inflammatory process, like a rash rather than a neoplasm.
Yeah, you know, another word I
Hard to
really
tell,
hate
but
for dermatologists to use is the word rash. I mean, we use it all the time, but that's for moms and kids, you know, and we say eruption, you know,
yeah,
that's more of a medical term. So we want to separate ourselves from the plebeians of the world. We should say it's an inflammatory dermatitis, or it's a, you know, an eruptive process, or an exanthamatous condition, something like that. It's more professional, if you ask me. So you're right, though. This is an inflammatory process. Good. What's the pattern?
it's kind of mixed, it looks like to me.
But overall, before you go too fast,
yeah,
what's the general pattern? We're staying here at 10,000 feet here. We're not 30,000 anymore. We're 10,000. So what do you see here?
I think it almost looks like not like nodular inflammation almost, or there's
Well,
perivascular, superficial, and deep inflammation for sure.
but
And
what?
then there's the
Wait a minute. Hold on. What's right here? What's the arrow pointing to? What is this thing here?
I mean, I guess that's all spongiosis in a blister.
It's a blister. Blister. Good. Now we've already had one blistering disease today. What's the situation here? So we know we're talking about blisters. They can either be intraepidermal or subepidermal. So which one is this one this time?
I think it's intra.
We had
Although,
50%
no,
chance.
sorry, that's subepidermal right there.
Subepidermal blister. Subepidermal. Good. Excellent. Okay, so we're in the subepidermal blistering disease category. Dr. Yancey would be proud of you now. So what's the next step?
Well, is it inflammatory or not?
Good. Good. What about this one? Now, this is where the rubber is going to meet the road here. You're going to learn a whole lot on this slide here, because this is something you haven't seen before.
I mean, I think it's inflammatory.
It's totally inflammatory. What kind of cells?
Neutrophils.
Good. Neutrophils. No eosinophils.
Yeah, no, he is.
Okay. Now, so what do we think about? What's the reflex arc when we think about a subepidermal blister with neutrophils predominating?
Mhm.
So
Wow.
3 diseases. There should be about.
Neutrophil rich BP.
Okay, good. That's probably that's a zebra, but that is in there. You're right. It wasn't the classic I was thinking about. What are the 3 classic ones?
MMP.
Well, that's in there too.
Mucous membrane pemphigoid.
Classic ones. The 3 classic ones are
Linear IgA.
linear IgA. Good. What's the second one?
DH.
Good.
Although
That's the second one. What's
Okay.
the third one? The classic ones. You've already said 2 non-classic ones. You need to know those too. I'm glad you know those, but I want you to make sure you know the classic ones first.
Bullous lupus.
Good. That's it. Those are the 3 classic ones. Now you've named 2 others that are not classic. Now let's look at this roof of this blister. Now, this is where you're going to really learn something. So what do you see here? We've already seen one roof of a blister where it was confluent epidermal necrosis. What do we see in this roof of the blister? You can learn a lot from looking at the roofs of blisters. You can learn a lot by looking just at the cornified layer of things. You can make the diagnosis of psoriasis just looking at the cornified layer. Make the diagnosis of tinea versicolor. I mean, Dr. Ackerman he wrote a whole chapter of a book one time, I think, just diagnosis based on the cornified layer alone. So you can do that in many cases. But what do we see here when we look at the roof of this blister? What am I pointing to right here?
Hold on, I'm at the VA. My thing is, oh, okay. This pinkish material.
Yes. What is that? And what if I showed you this and there was no inflammation and you saw this? These individually necrotic sort of keratinocytes, but this pink almost looks like a caterpillar running at the basal cell layer. And we look down here too, and we might be able to see some other clues down here. There's some festooning. Okay. And there's a lot of inflammation around these blood vessels, but there's some thick PAS positive with a PAS stain. This would be a thick basement membrane zone around these blood vessels here also. What disease do you see if this had no inflammation, where you get these so-called caterpillar bodies in the epidermis and you get a subepidermal blister on acral skin? And what if I told you the guy was a bad alcoholic and had hemochromatosis?
Yeah, I think Kishan logged off, but I popped in the chat, maybe PCT with the caterpillar.
Good.
body.
PCT. Excellent. How do we reconcile this with this inflammation?
Is it like secondary?
Well, this is something that you will not read in very many textbooks. You can sometimes get a rich neutrophilic infiltrate with PCT on occasion. And if you do immunofluorescence biopsies of PCT, you very commonly see deposition of multiple immunoreactants at the dermatdermal junction, really a thick diffuse coarse granular deposition of IgG, C3, IgA, IgN. You get multiple immunoreactants also around the blood vessels. So when you get all those immunoreactants, shouldn't they sometimes bring in some inflammation? Yeah, sometimes they do. So sometimes you actually get some PCT lesions with inflammation, and that's not in the textbooks. I always talked about it being a cell pore infiltrate with the festooning, with the caterpillar bodies. But just so you'll know, sometimes you can actually get PCT with abundant neutrophils. So just remember that. It's something that most residents in dermatology don't know. And another thing that can happen is if you get necrotic keratinocytes, they can sometimes be chemotactic for inflammatory cells. You release all those wonderful lysozymes and everything sitting inside those keratinocytes and enzymes and proteins, and they can be a chemotactic for neutrophils and histiocytes and other things there too. So that may be the pathology of it. But I will tell you that I've seen that happen many times over the years, and it's not something that a lot of people know. So now you do know it. Okay. And you can also see pseudo PCT can look almost identical to PCT. So just that's something to add to your diagnostic armamentarium. Okay. Now this one was kind of curetted, but there's a reason that they kind of did that. So we'll take a look at it. This will tell us where we are on the body.
Yeah, I can try this one. So it looks like it was an acral
Good.
lesion, dark blue cells. They don't look,
Good.
as small as lymphocytes per se, but it has kind of these like fenestrations or kind of like slit-like spaces.
Yeah, they've got holes. That's good. Good observation. There's little holes in here, and we're going to figure out what those are. So obviously you're thinking at low power inflammatory versus neoplastic. What do you favor here?
Neoplastic.
Neoplastic. Okay. So I want you to be thinking, I recognize acral skin, just like there's certain reflexes that you develop. I kind of want you to develop some reflexes with regard to when you see something in a certain area, it's sort of something that's blue, epithelial, acral skin. I want you to think about a relatively few number of entities that can do that. So we're going to higher magnification here. Do you think this is likely to be benign or malignant here?
I want to say, I haven't looked closely at the cells, but it's pretty large, but it has a benign feel.
It's hard to be sure But this thing was probably relatively large, and they probably tried to scoop it out, and they said, "Uh-oh, it ain't scooping out so easily," and it's probably a very relatively large lesion. It's very difficult to assess symmetry and some of those things and something like this. But when we see something that's kind of fragmented and that's pretty large like this, you should at least be concerned that it might be malignant. And then we're going to higher magnification. We're going to see if we can see other features that kind of help us one way or another. And now, what do you see here? Those slit-like things that you saw, what do they look like now?
Yeah, I mean, some of them had what do you call it? Blood in them earlier, but most of them I think have this like pink spongy material that looks kind of like sweat. More
Good, excellent. It's a proteinaceous material, exactly right. So it's some kind of a secretion. So these are glands here.
Yeah.
Glands. And notice that it's relatively solid over here. We'll keep scrolling around. There's some pleomorphism of some of the cells here, and we might find a mitotic figure or two in here. Definitely some pleomorphism when you look at this field. But this entity is one of the ones that sort of is a wolf in sheep's clothing sometimes. It's not super atypical. You don't see a lot of mitoses in this entity. But what do you think about when you think of what looks like a glandular neoplasm? Pretty solid, very cellular. It's got some pleomorphism on an acral skin site. What diagnosis comes to mind?
Well, I guess if in the malignant category, maybe like a digital papillary, like adenocarcinoma.
Good. That's exactly what I want you to think about in this. So in other words, when you see something like this, there's certain things that when you see 2 + 2 = 4, you say, well, it's 4 until proven otherwise. So when you see something like this on acral skin, even if it's not super atypical, we don't see a lot of mitoses, you think of that entity and you say, I've got to talk myself out of that diagnosis. And when I look at this, I don't see anything that's going to talk my way out of it. You know, it's got the cells it's cellular. There are some scattermitotic figures. It's got pleomorphism. It's asymmetrical. It's pretty glandular over here. It's pretty solid in other areas. And it's fragmented. We don't really know what this whole thing would have looked like if we could have gotten an excisional biopsy, but it probably would have been asymmetrical. So that's exactly what this is. This is an aggressive digital papillary adenocarcinoma. And they're called aggressive, which is a good name because they actually are pretty aggressive. And even if they don't have a lot of atypia, a lot of mitoses, a lot of pleomorphism, they can still behave in an aggressive fashion. They actually they metastasize to local lymph nodes up in the elbow and the axilla fairly commonly. They can have widespread metastases sometimes. So once again, if you ever see something like this on an acral skin site, you should instantly think of the diagnosis. And one other thing I'll sort of say too, as a clinical pearl, you know, one of the other reflexes that we have as dermatologists is skin lesion, skin biopsy. But you should think about, before you do a biopsy, maybe doing, especially in an acral skin site, imaging study pre-biopsy. Send them off for an x-ray, you know, something like that. See if the bone's involved. You know, maybe it's a osteosarcoma or something like that. Maybe it's a benign lesion of the bone. And radiologists can look at the bone lesions and things like that coming off of a digit and give you a preliminary diagnosis. They look at things and they can make diagnoses based on the radiologic appearance. So that's something that I learned also. So before you take a biopsy of the nail unit, think about doing an imaging study first. Even if it looks like a melanoma, it may actually be some kind of an underlying tumor that's got a hemorrhage in it, or maybe it's a pigmented onychomatricoma or something like that. So always think about doing an imaging study pre-nail unit biopsy, and it might show you something. Okay. You guys have time for one more?
I think we can do one more.
Okay. This is a good one. It's a fun one.
So this one, it's like a very large nodule in the dermis.
Okay.
Punch biopsy. I think I can't tell if this is maybe acral skin with how thick that stromal cream is.
It is. Excellent. Inflammatory neoplastic process here.
So I think it's inflammatory.
Good. You're right. It's inflammatory. What pattern are we looking at here?
I mean, it's like a granuloma.
Good.
Like,
good. Excellent. And then what's going on in the granuloma here? Now, this sometimes can be a little challenging because it It can simulate a palisaded granuloma, but this actually isn't palisaded granulomatous inflammation.
Is it necrosis?
Good. This is necrotic. These histiocytes have undergone necrosis. Okay, so, and again, the necrobiosis word again, this time it really is degenerated necrotic histiocytes. So this is what we call caseation granulomatous inflammation, which is seen in the so-called tuberculoid granulomatous pattern.
Yeah.
So what do you think about there?
I mean, you would think of like leprosy potentially.
Think of an infection. Yeah. Exactly. And yeah, you do think about acid-fast bacillary infection.
Sorry, I know that there's the stain associated with this one, so.
Yeah. Okay. So you said leprosy. Let's look at it. Is this a typical pattern of leprosy?
No.
No, it's not. What pattern is this characteristic of?
What do you mean?
Well, so it was positive here. I hope I can see it on this. I'm not seeing a lot of organisms here. This was positive. Did you guys see the organisms in here?
I actually, like, there's staining, but it looked really like, I mean, the globs of staining are very non-specific. I couldn't find any organisms though.
Yeah, they're definitely in here. It was positive. That's why I wanted to show it to you. That red junk up there, this isn't it, but there are some organisms in here, and it's hard to see with this projection, but I know we saw them, and I know it's got a positive culture. What's interesting is when we're looking, you don't see a lot, and that's actually fairly common. Sometimes you'll see like a fairly brisk inflammatory reaction like this, and you'll look hard, you maybe see like 1 or 2 organisms, not a lot. We had a case the other day that had about 1,000 organisms in it. You easily see that. But here, you have to really kind of scroll around and look hard. And the best place to look when you're looking at an AFB infection is in the caseated area. You almost always will find some organisms in here. I apologize, I can't see it, but they definitely were in here, and this actually had a positive culture. So this is the pattern that you see in patients that have cutaneous tuberculosis. Usually like Mycobacterium marinum will kind of give you more of a suppurative granulomatous dermatitis. If you get tuberculosis varicose acutis, that like prosector's wart, that sort of thing, they give more of a verrucous epidermal hyperplasia. But if you get like some of the atypical mycobacteria like M. kansasii infections or M. avium intracellulare, they can give you these kind of patterns here that give you this caseation degeneration here. So this was an example of an atypical mycobacterial infection. I wish we could see the bugs better here, but if you maybe go back and look, you might be able to find them. If they show you one on the exam, they're not going to give you one that you have to seek and, hard to find. You'll actually be able to see them.
Gotcha.
So this was an example of an AFB infection. Okay, I'll send you guys off to clinic. Good
Thank
job.
you.
Hope you guys learned some things, and we'll have a great, I guess we're going to do maybe one more time before the end of the year.
You're gonna pre-record one at Christmas time for us, is what the schedule says. So
I'll give you a Christmas present.
thank you.
All right, you guys take care.